Welcome to this session, keynote session at People and Planet United. I'm Christopher Nial. I'm a senior partner at Fin Partners Global Health Impact, and I'm joined by my colleague and a managing partner of Global Health Impact, Mark Chataway. Over the next 20 to 30 minutes, we want to make a case that the sustainability conversation in healthcare needs to move, and that the evidence for doing so is stronger than most people realize. We'll draw on economic data from the Vifor Institute and demographic projections of the UN to argue that prevention isn't a nice to have, it's the main lever for both planetary health and health systems survival.
And Chris, it's important to say that by prevention, we don't just mean primary prevention. We do mean primary prevention. We mean stopping people getting sick in the first place, but we mean secondary prevention, which is stopping people getting sicker than they are, stabilizing them, making them a bit better if we can, stopping chronic diseases relapsing. So it's both kinds of prevention we mean.
That's a good point, Mark. Thank you.
So, Chris, long time discussion about the sustainability agenda around health, and it tends to focus on these three elements and the net zero targets linked to them. So it tends to focus on hospitals use a lot of energy. Yes, they do. They have to keep sick people warm. They have to keep operating theatres cold. They have to keep the lights on all the time. All the reasons we're going to talk about, by the way, for improving health, because sick people do use a lot of energy. So hospitals use a lot of energy, and treating sick people uses even more. For infection control, for other reasons, we have a lot of single-use plastics, a lot of waste streams coming out of operating theatres and wards and pharmacies. And an area where things have improved is that hospitals have really focused on the supply chain and on disclosures, procurement standards, decarbonizing the supply chain, because there's a limit to how much you can decarbonize hospital operations, but you can decarbonize the supply chain. So these are all the things that we conventionally talk about. You and I think, Chris, are going to make the argument today that they're probably not where our focus should be.
Exactly. In every healthcare setting, not just hospitals, in every healthcare setting, where they produce a sustainability report, we see the operational footprint section is very well detailed, and the working out how to mitigate these situations. But it's really that I think we're going to focus today on the upstream story, Mark. What's driving the demand that generates that footprint spend?
And why better health would actually reduce our footprint as a species on the planet.
Exactly.
So this is it. What if the greatest contribution a hospital can make to planetary health is helping fewer people need acute care? Now, it's important to say that what we're talking about here is acute care. We're not saying don't go to a hospital. We're not saying don't go to a doctor. We're not saying don't use healthcare. Not at all. What we're saying is don't get taken into hospital because you're in some kind of a crisis. You're in some kind of urgent situation. That's what we want to reduce. And that's what can make a really big impact on both the environment and on the economic prosperity and well-being of society as a whole.
Exactly. If you hadn't said it, Mark, I would have reinforced we're talking about acute hospitalizations here. We still perhaps want people going to hospital for prevention measures, but not for acute care.
And planned surgery and things that we can't get around, things that we can't avoid. And there will always be acute care. Of course there will. People are sadly always going to have heart attacks. But we can reduce it. We can minimize it.
Exactly.
So, I mean, the health sector is an enormous part of our economy. And because it's an enormous part of our economy, of course, it's kind of a tautology to say, but it has a big impact on our economic well-being. It also, of course, has a big impact on our environmental well-being for that reason as well. So globally in 2022, and the figure's almost certainly gone up since then, about 7% of global value added, about $7 trillion it was linked to healthcare. And that's about 200 million jobs globally.
Exactly. And in the EU alone, health is the single largest economic sector. That's worth mentioning.
Now, as you would expect, probably the footprint from this is quite high. You'll notice that actually it's under 5% of global greenhouse gas emissions, and since it's 7% of global value added, we're not doing badly. But there's always room for improvement. So healthcare is responsible for about 5% of global greenhouse gas emissions, and that can be reduced if we get the mix right in how we provide healthcare. Things work the other way as well. So environmental problems create a lot of the usage of the healthcare system. Air pollution, a prime example. If you live in Delhi, you probably live about 7 years less than you would if you lived somewhere else on average. Or if you lived somewhere that was less polluted, let me stress that. Don't move from Delhi to Beijing. But if you live somewhere less polluted, you'll probably get another 7 years of life expectancy. So air pollution causing not just respiratory illness, but a massive amount of cardiovascular illness. And that cardiovascular illness is a prime driver of hospital usage. Climate exposure, we know that the changing climate is having a few positive effects. So in Northern Europe, in North America, we're seeing fewer cold-related deaths, and a few vector-borne diseases like dengue appear to be getting a little less serious. But that's outweighed by an enormous increase in diseases which like heat. So top of the list, malaria. We already have 600,000 children a year dying of malaria, and sadly that number is increasing, despite the fact we have increasingly good prevention methods and almost perfect and very cheap treatment methods. So there's a whole discussion around that. But one of the things we have to bear in mind is that as the planet heats up, we will get more malaria. Rwanda, as a country, had made massive strides against malaria, and they're now being lost because as the planet heats up, mosquitoes are going higher and higher and higher in altitude, and Rwanda is a country of mountains. And then climate change is causing poverty and food insecurity. So we know that it's wreaking havoc with the ability of people to grow crops. There are issues like desertification, growing water shortages. Those lead to poverty, and that poverty and that food insecurity is another major driver of chronic ill health.
That's right. From a clinical perspective, and every hospital executive already knows this, patients are coming through the door, are sicker and older, and arriving with conditions that were preventable.
So treatment cannot absorb the changes that are going on in our society. Now, the global population is still growing. I'm a little embarrassed, I have to admit, Chris, by this, because I was one of the people who said the vast threat, the existential threat to us is population growth. That's no longer the case because the population will peak, as you've said, here in the 2080s, and will then go into a pretty rapid decline. And for many areas of the world, population decline is as much of a problem as population growth and population aging. So the population of China will more than halve by 2100 and will, on average, become very, very elderly. And of course, older people, sadly, a fact I'm realizing personally, are bigger consumers of healthcare services than younger people. So this needs to reconfigure health services and to keep people healthy becomes increasingly urgent as our societies age. So you've given this figure here, Chris, that by 2070, the number of people age 65 plus will surpass those under 18 for the first time. Actually, that will happen in Germany this year. So I think I'm right in saying it will happen in Germany this year. There will be more people either over 60 or over 65 than under 18. So, of course, Europe at the cutting edge of this demographic transition. We've actually already been through the second demographic transition, mostly in Europe. And now the big impact will be in Asia, in Latin America, and in the Eastern Mediterranean, North Africa. And so this and the growth in very old people, and of course those of us who are only slightly old really like talking about the very old. No, the growth in the 80 plus cohort will be particularly dramatic, and that's partly because we're good at health, right? It's partly because people are living longer, as I think we're going to talk about in a bit, though, Chris. They're not necessarily living healthier, longer lives.
Exactly. It's that gap between the 65 to 80. I don't think we've got a name for the 80 plus cohort yet, but the 65 to 80 cohort actually are what some people call the second demographic dividend, an age, a group of people who are currently considered to be a drain on society, where actually they can contribute a lot to society. Sorry, they're well off with good pensions. They are volunteering. They're providing unpaid care work as well. So the people in that age group are actually a benefit, a dividend to society.
Yeah, I mean the controversial bit of this, Chris, is that people have to work longer, and that's unpopular, but it's true. When Social Security was introduced in the United States in the 1940s, people on average lived long enough to claim it for about 3 years. So they became eligible at 65, and the average life expectancy was 68. These days, they on average claim it for 20 years. And that's simply not sustainable. And in Europe, it's longer because Europe's life expectancy has surpassed the US some time ago. So that's simply not sustainable. In China, it's least sustainable of all. Many Chinese retire in their 50s and can expect to live into their 80s. So the unpopular bit is people have to work longer, but it doesn't mean they have to work full time. It doesn't mean you're 75 and you have to go and do a 40-hour week. We have to find ways of adapting work so that we use the experience and the skills of older people, but maybe in a more flexible configuration, and that might be that they're working 15 hours a week or 20 hours a week, or it might be that they can take 3 months off to go on a cruise and then they can work 9 months a year, 30 hours a week, something like that. Because people are becoming more valuable, despite what AI is doing, because people are becoming more valuable, we have to configure workplaces to keep more people at work. But as you pointed out, Chris, the two other bits of value are the impact of older people on the rest of society. So volunteering, looking after the children of women who otherwise couldn't work, because it's nearly always women who do childcare, and spending. So disposable income is overwhelmingly held in our societies by people over 55. The key to having a really prosperous and high growth 20 or 25 years ahead of us is to keep those people well enough to spend.
And this is the structural argument for prevention.
Absolutely. It's the structural argument for keeping people healthy through prevention. Absolutely. Absolutely. That's right. But you've said less than 5% of health spending goes to prevention. Actually, that was only true at the peak of the pandemic. Routinely, less than 3% of health spending goes to prevention. And there are some countries in which it's less than 1.5%, which is astonishing. And then a chunk of that goes to prevention that doesn't work. So there's what a client at Sanofi calls health prevention washing. He says it's like greenwashing. You say, oh, yes, it's health prevention, and you label it that, and then you count it towards the 3%, and actually it's doing almost nothing. So motorway improvements, for example, the cost per quality adjusted life year saved is well over $1 million per quality adjusted life year saved. It has a negligible impact on prevention, but it's counted as prevention spending sometimes. So much too little spent on prevention as a whole. And by the way, we look at prevention wrongly. We look at it as spending. We look at it the way we look at spending money on treating my bacterial infection, right? That's money out of that we spend now to achieve a good now. It's actually much more like a bridge. It's actually much more like building a bridge or installing a fiber optic network or building electricity supplies. Because when we invest in prevention, we're investing in taxes paid, money earned, money spent over the next 20, 30, 40, 50 years. So that's how we should be treating prevention spending. And our challenge is we have to look at different ways of treating it because we already have a shortfall in global health investment, and we can't afford to compete for the same dollars that are being spent on super specialty hospitals.
Exactly. And it's, it's a part of the cycle that we're going to come on to a bit later. But I just want to mention that, doctors have actually been arguing this case for a very long time. And it's just now we need to find a way to translate that advice into policy.
So we've set out here three steps, courtesy of our colleagues at Vifor. For people who don't know Vifor, it's a German economic research institute, which spends a lot of time thinking about what the evidence really says on how government should be spending money to maximize the benefit to society. And often the answer to that is the government should be spending money on health. So the return on investment. First of all, you have to know what the burden of bad health is, and we don't know that. We know what the burden of bad health is because we say, okay, well, we know that it takes 5 days in hospital, and we know 5 days in hospital costs $5,000 a day, €5,000 a day. So that's €25,000. But that's actually only the beginning of the costs of bad health. The costs of bad health are lost economic activity, lost tax revenues, lost multiplier effects in spending. There are all sorts of burdens that we don't measure. And then we should calculate the social impact of alleviating those burdens, right? So we should say, if we have a new vaccine that can prevent pneumococcal disease in adults, for example, or we have a new vaccine that can prevent hepatitis C, which the good Lord willing we will have in the next few years. What is the full social impact of that? It doesn't just keep people out of hospital. It creates all the positive sides of those burdens I was just talking about. And that allows you to quantify the real economic return, not the return just to the healthcare system, not, I've achieved a quality adjusted life year saved for below a threshold of €25,000 or whatever the artificial threshold is, but I've created these benefits for society. And a part of that has to be looking at the environmental benefits you've created for society. So we have to look at the economic benefits, certainly, how much tax revenue have I earned, but also how many greenhouse gas emissions have I averted? How much have I been able to limit the impact of healthcare and climate change? There are three sets of economic ledgers. Could be the same country, the same disease. This is what we typically look at. We typically look at how many years of life have we lost, 1.6 million, or we typically look at how many healthcare costs have we averted. But then we want to look at how many hours of lost productivity have we avoided, or how many hours of lost productivity has a disease created. And we want to look finally at how much of the potential value that could have been added to society has gone. And it's worth saying, right, Chris, as you say across the bottom there, that over 90% of that productivity loss is not people not going to work, it's unpaid work.
Exactly. As I was talking before about that population between the 65 to 80 group who are unpaid carers and volunteers as well.
So, Chris, these three diseases, these three settings, the same direction of return. If we are successful in preventing disease, or at least in mitigating the impact of disease, by early intensified treatment, that secondary prevention I was talking about, we potentially can save hours of work time. We can potentially avoid events. We can do things that we're used to measuring, but we can also add to the productive capacity of society. And by adding to the productive capacity of society, we can also get a double impact or a triple impact sometimes, because the people who are earning money are also going out and spending it.
Exactly. Three different diseases, three different countries, but the same story. Prevention doesn't just save money, it generates it.
So we often talk about vicious cycles. This is a virtuous cycle, uh, because better health improves productivity. Better productivity improves growth, and more growth creates more headroom for innovation, more funding to invest, more potential to discover new ways of doing things that then feeds into better health, and the cycle starts all over again.
Exactly.
So we have to create a narrative. And this is, I think, one of the places that the healthcare sector can really come in. Chris, you said a few minutes ago that doctors have been saying this for a long time. Well, they kind of have. But they always think, and I suppose it's the mindset of a doctor, right? They always think it matters less than the biomedical things you can measure, that it matters less than the hospital visits averted or the episodes that don't happen. Of course, to policymakers, it matters at least as much that we can fund all of this from existing resources, and we can build prosperity along the way, and we can improve the environment. So I think a part of it is that we have to train people in the healthcare system in how to make the case better.
Exactly. I've seen this firsthand. Health system leaders know this story, but they don't have a platform yet. They don't have the messaging or the coalition infrastructure to tell it at scale. And this is where good communications and public affairs, for example, become strategic, not just operational.
I was having lunch a few years ago with somebody within a health ministry. I won't say which country. And we were talking about HPV vaccines, and I explained why they were such a good investment. And he looked at me and said, if the health ministry had made this argument, I would have funded them 3 years ago.
Hmm.
And it's not that I'm particularly brilliant, it's that I've spent enough time around policymakers to know what it is that they need to hear in order to act. And I think if you're a scientific genius who's spent your life making people healthy, you don't necessarily know that. Why would you? So here are 6 things health systems can do with their voice. They can stop only talking about the health impact of spending, about the humanitarian impact, about the things they care about as hospital administrators, as doctors, and reframe it in terms that economic policymakers care about. They can build cross-sector coalitions. These are things that, because of the environmental impact, they're a green allies. Because of the housing impact, I saw some data today showing how few people in OECD countries live in housing that's well adapted to older people. Israel, by the way, is the outlier, has a very, very high percentage of its housing adapted to older people. But most countries do really badly. So build cross-sector coalitions, and of course, employers, trades unions, health insurers are a natural part of those coalitions. Equip the leaders of those coalition partners as public voices through media training and thought leadership. And you've put op-ed programs, Chris, which is showing your age and mine, but having a voice on Substack and a place on Medium, and if they're really good. Chris and I both live in Ireland, and the deputy prime minister in Ireland does everything on TikTok. So if they're really good, teach them how to do it in a 30-second TikTok video. Engage the payers. Employers are willing to do this. Employers are willing to bear a share of the costs if they can see these outcomes, and are certainly willing to engage with government. We can't afford to do this in a way that grows inequity in society. Every life in an age where society is becoming older, and in a time where we are seeing fewer young people, every life is more valuable than ever. And I do mean every life. So we have to make sure we keep an eye on health equity. And then we have to track whether the conversation is shifting. And if it's not, we have to rethink and go back to step one.
Exactly. Mark, I'm going to put you on the spot now. We've been advertising that we're on through our social media that we're talking at the summit, and we invited people to send some questions in. You haven't seen the questions, I have, so on the
Uh-oh.
next slide are the questions. So I'll dive
Uh-oh.
straight into them. If we've got time, we'll do the best we can in the time we've got. Um, uh, aren't you asking hospitals to argue themselves out of business?
No, we're asking them to change their business model. So the number of hospital beds per capita of population in advanced economies has already shrunk enormously over the past 50 years because fewer and fewer people have to go into hospital for a week or 10 days or a month at a time. But that doesn't mean that hospitals have become a less important part of the economy. In fact, they've become a bigger part of the economy. So we're asking hospitals to become these centers of secondary prevention, and hospitals are already thinking that way. I was with a group of hospital leaders a few months ago who were saying that their most valuable lesson had been learning how to keep people out of hospital for longer after procedures. And they bought a taxi company because they'd realized that one of the reasons that people were coming back into hospital is they couldn't find a way to come in for follow-up visits. So they bought a taxi company because they figured it was cheaper to own a taxi company than to have people have health crisis after health crisis. So no, we're asking to change the business model.
Very good. Um, so it's noted our evidence that we've discussed, and you and I have been discussing this for some time now. This is just a first opportunity to talk about it in a public forum. And the evidence we've been using a lot is mostly European. And somebody asked, does this also apply in low and middle income countries and settings?
It doesn't also, it much more applies. So there's a statistic from the African Development Bank showing that if Africa had better health, it could double its GDP. Uh, the impact is all the more striking in countries that historically haven't invested heavily in health. So sadly, the average African country is spending under 2% of GDP on government funded health. Now, I'm not saying only government funded health is worth having, but total health expenditure is also typically under 5%. If you start to increase that and you do it effectively and efficiently, and you don't do it on super specialty hospitals, but you do it on keeping blood pressure under control, for example, you can have dramatic economic effects very, very fast. So it looks different because the demographic transition is happening on a different timescale in most low and middle income countries. Although there are middle income countries now that are going to have very rapidly aging populations. So it looks a bit different depending on where you are, but the core lesson is the same.
Got it. And you may have already partially answered the next question. Prevention savings take years. How do you win a budget cycle with a 4, 8, 5, 10-year payoff, for example?
No, it's a really key thing. But I should have said something else about the low and middle income countries. The
Hmm.
impact of climate change is, of course, more acute in most
Of
low and middle
course,
income
of
countries.
course.
Therefore, anything we can do uh, by keeping people healthy to alleviate climate change is of exceptional importance there. How do you win a budget cycle with a 10-year payoff? It's a big problem because the woman in the health minister's job today is definitely not going to be in that job in 10 years' time, and she may not even be in politics in 10 years' time. So how do you convince her, don't spend the money on some high-tech new MRI suite where you can go and open the ribbon and get lots of positive publicity, spend it on vaccination. And what happens when you vaccinate people and it works well? Nothing. So how do you win that case? I think there's a couple of things happening. The OECD, the Rich Countries Club, is talking about creating a competitiveness index, where a bit like the PISA index in education, it will rank countries on how good their prevention spending, their preventative healthcare spending is, and you get to go up and down the index. So I think that's really good because our health minister can walk into cabinet and say, look at me, I got us 4 places up the index," and that really helps attract investment. That reassures the population that you're on the right track. I think, secondly, Professor Ostwald of the Life Institute has been talking to credit rating agencies. And the credit rating agencies are saying, well, high spending on prevention should be associated with lower debt costs. Now you're talking, right? Now you suddenly have the attention of the Treasury, the finance people, in a big way. So again, our health minister gets to walk in and say, thanks to me, we've gone from B plus to A minus. Wow.
Good point. I'm going to have to keep you very brief on this last question, Mark. What's the one thing a health system leader could do tomorrow?
Wow. That is a difficult question. That is a difficult question. I think the one thing that a health system leader can do is start to change mindset, right? So if every time a health system leader is talking about health, they say, and health has an effect on the economy, health has an effect on national well-being, health has an effect on the environment. If every time they talk about health, they talk about the consequential effects of health, that will change the atmosphere in society.
Thank you, Mark.
Thank you, Christopher.
So, Mark, I'll let you take the last word in a
No, you
sec.
should you should definitely take the last word.
Thank you. Well, I just want to thank everybody for joining us. The core message is simple. The most powerful thing a hospital can do for the planet may be to use its voice, its policy in public debate with the players and employees who share the financial exposure to preventable disease. And I would be remiss in not reminding people what you and I do at Fin Partners in the Global Health Impact Group. And it's very much about providing people with we take this evidence-based data and we translate it into a usable narrative. And I will give you the final word, Mark.
No, that's exactly right, Christopher. And these are the kinds of things we enjoy engaging on. And I think they're increasingly important arguments because we're in a time of squeezed public expenditure, and it's really important that health doesn't get squeezed out.
And if you do want to find us, simply search Fin Partners Global Health Impact. Thank you.